So, welcome to this session on hip joint. Hip joint is, let's start with type of joint, and before that, some introduction. In hip joint, the stability is compromised for mobility. If you compare it to the shoulder joint, in shoulder joint, mobility is stabilized, is compromised for stability. Shoulder joint is more mobile, less stable. Comparatively, hip joint is more stable, less mobile. When we ask about the type of the joint, it is a multi-axial ball and socket type of joint of synovial variety. Multi-axial ball and type of joint of synovial variety. Okay. What are the articulating surfaces? The articulating surfaces uh, we talk into one is superomedial. Superomedially is the acetabulum. To be precise, the lunate surface of acetabulum. Lunate surface of acetabulum. And the acetabular notch, which is traversed by transverse acetabular ligament. So superomedially is lunate surface and transverse acetabular ligament. And inferiorly and laterally is the head of the femur. Okay, it is called by the hyaline card. So head of the femur. So these are the two articulating surfaces. Inferiorly, we see the head of the femur. It's like fovea is also here. So head of the femur is there. Okay. Now the head is, how this is kept stable. One is there is a acetabular labrum which is surrounding the acetabulum, which deepens the acetabular cavity. Okay, there are strong ligaments, very strong ligaments. So stability is of this joint is maintained by the acetabular labrum. Strong ligament, rather the Bigelow's ligament, the iliofemoral ligament is the strongest ligament in the body. Okay. Then let's talk about the capsule and ligaments. How do you remember the capsule and ligament? There is of course one capsule, and ligaments are 3 plus 3. Okay, there is this one capsule and there are 3 ligaments, 6 ligaments total. We group them as 3 plus 3. The first 3 group arises, one from the pubis, one from the ilium, and one from ischium. Remaining 3, one is acetabular labrum, another is transverse acetabular ligament, and ligament of head of femur. So these 3 are not so strong, not so important compared to these 3, which are arising from each component of the hip bone: pubis, ilium, and ischium, and then is the capsule. Now let us talk about the capsule. The capsule is attached. The capsule is attached to the acetabular labrum and the transverse acetabular ligament. So on this side, it will be attached to the acetabular labrum and the transverse acetabular ligament. Okay, that's how the attachment of the capsule. Now, when we talk about the attachment of the capsule to the femur, okay, the attachment of the capsule to the acetabulum is along the labrum and transverse acetabular ligament. When it talk about the femur, it is attached to the intertrochanteric line anteriorly, and it is 1 centimeter medial to intertrochanteric crest on the posterior aspect. Okay, attached to intertrochanteric line anteriorly on the femur and 1 centimeter medial to the intertrochanteric crest posterior. This capsule has two types of fibers. Okay, one are one group of fibers which run from the acetabulum to the femur and are vertical. These are called as retinacular fibers. And the second group goes circular. Okay, and these circular fibers are called as zona orbicularis. So two types of fibers in the capsule: retinacular fibers, which are vertical fibers, and zona orbicularis, which are circular fibers. This capsule has some opening also. Okay, this these openings, why we should be knowing, because it communicates with the bursa deep to psoas major muscle tendon. So if this bursa gets infected, this can infect the joint also. Okay. After this, let's talk about the ligaments. So ligament number one is the iliofemoral ligament, which arises from the ilium and goes to the femur. This arises from anterior inferior iliac spine. Okay, anterior inferior iliac spine, and from the anterior inferior iliac spine, it is kind of inverted V-shaped or inverted Y-shaped, and the fibers go to the intertrochanteric line like this. Okay, on the anterior aspect. So this is the anterior inferior iliac spine from where it arises, and it goes in an inverted V or inverted Y shape. This ligament, iliofemoral ligament, is also called as Bigelow's ligament and is the strongest ligament in the body. The line of gravity passes behind the hip, and therefore the body has tendency, the trunk has tendency to fall backwards, which is prevented by this ligament, iliofemoral, the strongest ligament in the body. Okay. The second uh, ligament, number two, is pubofemoral ligament. This pubofemoral ligament, it arises from the iliopubic eminence. It will arise from iliopubic eminence. Okay. And if this is the iliofemoral ligament, and the pubofemoral ligament arises from the iliopubic eminence, and this fibers, they join this lower band of the iliofemoral ligament. So arises from iliopubic eminence and ends in the lower band. It joins the lower band of the iliofemoral ligament. Okay, so iliopubic eminence. From there, the pubofemoral ligament starts. Ligament number three is ischiofemoral ligament. Ischiofemoral ligament starts from the ischium near the ischial tuberosity, and this is the weakest ligament, and the fibers, they join the zona orbicularis. The fibers from there, they join the zona orbicularis. From iliac ischial tuberosity to zona orbicularis. Okay, so iliofemoral from anterior inferior iliac spine, it runs in an inverted Y-shaped manner. Okay, and is attached to the intertrochanteric line like this. Pubofemoral from iliopubic eminence and joins the lower part of the iliofemoral ligament. Ischiofemoral ligament from ischial tuberosity to zona orbicularis. Now let us talk about the ligament number 4. This is the ligament of head of femur. So if this is the acetabulum, this is the acetabular notch, this is the head of the femur. From here, the fibers go like this. Okay, so these fibers, they start from fovea capitis. Okay, and they run to the transverse acetabular ligament. That's about the ligament of head of the ligament number 5 is acetabular labrum. Of course, capsule is also one of the ligament, but I'm just acetabular labrum, which is made up of fibrocartilage. It is made up of fibrocartilage, and what it does is it is around this acetabular labrum is around. It is around the acetabulum. It deepens the cavity of the acetabulum. Okay, it is the head of the femur in position. And ligament number 6 is transverse acetabular ligament. This transverse acetabular ligament, the transverse acetabular ligament. This transverse acetabular ligament is this, which bridges the acetabular notch, and it just converts it into foramen through acetabular nerves and vessels pass through it. So through this passes the acetabular nerves and vessels. Okay, so total 6 ligaments. When we talk about the relations of this joint, anteriorly is the iliopsoas muscle. Okay, anteriorly is the iliopsoas. Okay, posteriorly will be all our tendon of this tricipital tendon, tendon of obturator internus, superior gemellus, inferior gemellus, quadratus femoris, and all this will be covered by main posterior relation, gluteus maximus muscle. Okay, main posterior relation is gluteus maximus. Superiorly is the reflected head of rectus femoris, and inferiorly is pectineus and obturator externus. Inferiorly is pectineus and obturator externus. So these are the relations. The blood supply. Blood supply mainly it is coming from the obturator artery and medial and lateral circumflex, femoral arteries. Okay, then there are they form a capsule around, they form an arterial circle around the capsule along near the neck, and from there the retinacular arteries they arrive and they supply the intracapsular part of the neck. Okay, there are some acetabular branches also which we talked about. Okay, which are from the obturator and medial circumflex, which go through this acetabular notch. So these are the acetabular arteries. So mainly obturator artery, medial and lateral circumflex femoral. The nerve supply. The nerve supply of this joint comes from the femoral nerve via nerve to rectus. It's come from the obturator nerve via the anterior and also from nerve to quadratus. Okay, and also by superior gluteal nerve. So total 4 branches. Okay, total 4 branches. Nerve, femoral nerve, 4 nerves which are supplying the hip joint. Femoral nerve via nerve to rectus femoris, obturator nerve via the anterior branch, nerve to quadratus femoris, and superior gluteal nerve. Now let us talk about the movements taking place at this joint. Okay, the movement, we talk about the movement, then we talk about the, sometimes we may talk about the range and mainly the muscles producing the, what are the various muscles. When we talk about the flexion and extension, they take place around the transverse axis. Transverse axis. Okay, the extension range is 15 degrees. Flexion means till the point the thigh reaches the thorax. Okay, the thigh reaches the thorax, till that point is flexion. Flexion is brought about by psoas major and iliac. Mainly, apart from that, there is pectineus, there is rectus femoris, there is sartorius. Okay, extension is mainly brought about by gluteus maximus and hamstrings. Okay, so flexion extension takes place around the transverse axis. Then the adduction and abduction, they take place around the anteroposterior axis. Adduction, abduction take place around the anteroposterior axis. The range of abduction is 50 degrees. Adduction, of course, is limited by hitting the opposite limb, and sometimes it may go little ahead of that also. The adduction, as the name suggests, is caused by adductor longus, brevis, magnus. Okay. Apart from that, there is pectineus and bacilli. Abduction is brought about by gluteus medius and minimus. Gluteus medius and minimus, and by tensor fascia lata and sartorius. Then there is medial rotation, the range of which is 25 degree, and lateral rotation, the range of which is 60 degree. And they take place around the vertical axis. Vertical axis. So flexion extension around transverse axis, adduction, abduction around anteroposterior axis, and medial and lateral rotation around the vertical. Medial rotation is brought about by gluteus medius and minimus. While lateral rotation is brought about by two obturators, two gamellae, quadratus femur. Okay. Apart from that, lateral rotation is also brought about by the gluteus maximus muscle, the piriformis muscle, okay, and sartorius muscle. Okay. So medial rotation by gluteus medius and minimus, and also by slightly by tensor fascia lata. While the lateral rotation is brought about by the two obturator, obturator externus and obturator internus, two gamellae, superior gamellus and inferior gamellus, quadratus femoris, gluteus maximus, the piriformis and sartorius. Now coming to the last component, that is the applied anatomy of hip joint. The hip joint, first applied anatomy, we might talk about CDH, congenital dislocation of hip, which is very common in children. Two, we talk about the diseases like TB of hip joint. This is also known. Okay, TB of the hip joint. Then there can be, we have to talk about hip replacement operations in case of arthritis. So we talk about hip joint arthritis first. This is also very common in people who have excess weight and they have to go for hip replacement. So we have acetabulum. Inside the acetabulum, we put a metal, and even the hip joint also is replaced by a metal. So hip joint replacement. Then Perthes disease. What is Perthes disease? Where there is destruction and flattening. Perthes disease means there is flattening of head of then there are some lines in the hip joint which we see on the X-ray. Like for example, when we see that there is a curve along the upper border of obturator foramen and lower border of neck of the femur. The obturator foramen is like this, and from here the neck of the femur is here. So this line is always continuous. Okay, and this line this is called as Shenton's line. This line is disturbed. This line is disturbed. Upper border of obturator foramen with the lower border of femur. This is obturator foramen. In case of fracture of the femur, this line may get. So these are some of the applied anatomic points of the hip joint. Again, we will revise the hip joint very fast. We started by saying that hip joint stability is compromised for mobility. It's a multi-axial ball and socket type of synovial joint. The articulating surfaces superomedially is formed by the lunate surface of acetabulum and the transverse acetabular ligament. Inferiorlaterally is the head of the femur. Regarding capsule, we said there is this capsule. Total ligaments are 7. Capsule plus 3 plus 3. These 3 are very minor ligaments and 3 major ligaments coming from ilium, ischium, and pubis. Capsule is attached to the acetabular labrum and is attached to intertrochanteric line anteriorly and 1 centimeter medial to the intertrochanteric crest posterior. The capsule has two types of fibers, retinacular fibers, which are vertical, and zona orbicularis, which go around. And the so there is an opening bursa, which communicates that this opening communicates with the bursa deep to the psoas major tendon. Okay, the psoas major tendon, muscle tendon. So this bursa, if it gets infected, it can infect the joint. Then the ligaments, iliofemoral ligament starts from anterior superior iliac spine, goes to the intertrochanteric line, inverted, Y-shaped or V-shaped. Cubofemoral ligament starts from iliopubic eminence and goes to the joins the lower band of the iliofemoral ligament. Ischiofemoral ligament, it starts from the ischial tuberosity and joins the zona orbicularis. It is the weakest. It is the weakest amongst all the ligaments. Then the 3 other ligaments are ligament of head of the femur, which starts from fovea capitis and goes to transverse acetabular ligament. Acetabular labrum, which surrounds the acetabulum, and the transverse acetabular ligament, which bridges the acetabular notch through which passes the acetabular vessels. The relations anteriorly is iliopsoas, posteriorly is this bicipital tendon and all covered by gluteus maximus, superiorly is rectus femoris, inferiorly is pectineus, obturator externus. Blood supply comes from the obturator artery, okay, and from the medial and lateral circumflex femoral artery, and some acetabular branches from the medial circumflex femoral and obturator. Nerve supply femoral nerve via nerve to rectus femoris, obturator nerve via anterior branch, nerve to quadratus femoris, and superior gluteal nerve. Okay, the actions are total 7. One is flexion, extension, adduction, abduction, medial rotation, lateral rotation, and circumduction. Circumduction is combination of all. Flexion, extension around transverse axis, flexion by iliopsoas, also pectineus, rectus femoris, sartorius. Extension by gluteus maximus and hamstrings, transverse axis. Adduction and abduction around anterior-posterior axis. Adduction caused by all the adductor longus, adductor brevis, adductor magnus, and pectineus and gracilis. Abduction caused by gluteus medius, minimus, and sartor. Tensor fascia lata also. Medial rotation takes place around vertical axis along with lateral rotation also. Vertical axis. Medial rotation is caused by gluteus medius and minimus and tensor fascia lata. Lateral rotation by the all muscles which are there on the posterior aspect. That is the 2 obturators of 2 gamellae, quadratus femoris, gluteus maximus, piriformis, and sartorius. Applied anatomy, congenital dislocation of the hip, very common. TB of the hip joint is also common. Hip arthritis, if becomes very severe, we can have to go for hip replacement. Perthes disease, flattening of the femur. There are lines like sentence lines where the upper border of obturator foramen is continuous with the lower border of the neck of the femur.